Welcome to this video on specimen collection and handling. This is a look at the pre-analytic phase from start to finish. We will cover accreditation requirements and practical bench-level procedures. Most laboratory errors happen before the sample reaches an analyzer. Quality control and calibration do not detect a switched tube. This video emphasizes identity creation at the bedside, with 2 identifiers required before any specimen is taken. We are covering the JCI and CBAHI standards. You do not need 2 separate documents. Simply write your procedure once and map it to the requirements of both bodies. This video is organized into 6 chapters, covering everything from framework and governance to specimen retention. These chapters apply to both inpatient and ambulatory settings. Chapter 1 focuses on the framework and governance of your collection manual, including how the document itself is controlled, distributed, and audited. The pre-analytic path consists of 8 auditable steps. For every step, you must have a written procedure, a record of the action, and a defined protocol for handling failures. Both accreditation bodies require the same core elements. Use a crosswalk table to map your single procedure to the corresponding citations for both JCI and CBAHI. Your collection manual must contain 10 specific elements grouped into what the laboratory offers, how to collect, and what happens next. It must be clear enough for any staff member to use. Compliance means more than just having a manual. It requires ensuring every collector has access, maintaining the current version, and keeping retired versions for the required audit periods. Chapter 2 covers ordering and patient preparation. The order is the very start of the specimen record and dictates the entire downstream process. Ordering policies must be strictly enforced. This includes rules for standing orders, add-on requests, and procedures for when patients arrive without a proper order, especially in ambulatory care. Requisitions must be complete and legible. Your accession record must allow for the retrieval of any specimen by date, name, or identifier to satisfy surveyor requests. Patient preparation is critical. This includes fasting rules, precise timing for postprandial or peak and trough tests, and proper technique to avoid hemoconcentration that could compromise results. Turnaround time begins at collection, not lab receipt. You must define routine and stat windows, monitor performance, and account for external constraints like courier schedules in your published figures. Chapter 3 shifts our focus to the fundamentals of identification and labeling. We will look at the 3 core rules that ensure identity is never lost. Identity begins with 2 identifiers, and there are no exceptions. Acceptable identifiers include the patient's full name, record number, date of birth, or a barcoded wristband. Never rely on location identifiers like a bed or room number, as these do not move with the patient. Inpatient and ambulatory settings follow the same rules but require different controls. For inpatients, always check the wristband. In ambulatory settings, where wristbands are absent, use active verbal identification and reconcile against the registration to prevent errors. Special populations require unique protocols. From assigning temporary identifiers for unknown patients to maintaining strict chains of custody for forensic specimens, each situation must have a written, trained, and standardized procedure. We must address common failure modes, like pre-labeling tubes or batching labels. The control is simple. Integrate identity verification and labeling as part of the collection process, never as a separate or post hoc task. 3 rules of labeling are absolute. Label at the patient's side, label after the specimen is in the container, and label every container individually. Breaking these rules breaks the link to the patient. Every label must include 2 identifiers: the collection date and time, the collector's identity, and the site where applicable. If identification fails, the default response must be rejection and recollection. Technology, like barcode scanning, can reduce errors by automating timestamps and verifying information. However, it does not replace the fundamental requirement for active, manual patient identification and verbal verification. Moving into Chapter 4, we explore collection practice. This covers who is authorized to collect, where not to perform a draw, and the precise techniques for taking different specimen types. Everyone who performs collections must be held to the same standards, whether they are lab staff or clinical nurses. Competence must be proven by direct observation, not just attendance records, and performance must be monitored. Site selection is vital for safety. Always palpate to find a viable vein. Avoid areas like mastectomy sites, IV lines, or scarred skin to prevent complications and ensure accurate testing results. The order of draw is based on preventing additive carryover between tubes. Following this sequence protects your samples from contamination, ensuring that the results you report reflect the patient's actual physiology. Proper fill volume and gentle, immediate mixing are essential. Underfilled tubes or poor mixing lead to ratio errors and clotting, which are leading causes of unnecessary rejections and recollections. Hemolysis is a major preanalytic problem. By focusing on technique, such as choosing the right needle gauge and avoiding excessive force, you can significantly reduce this hidden cause of inaccurate results. Blood cultures are high stakes. Strict aseptic technique is your only defense against contamination. Remember that volume is the biggest determinant of culture yield, so prioritize accuracy in your draw process. Finally, urine collection is frequently misunderstood. Because it is often collected by patients, your written instructions are the primary control for preventing poor specimens and ensuring timely transport to the laboratory. Moving on to special specimens, cerebrospinal fluid requires precise handling. Collect 4 sterile tubes in order. The first for chemistry, the second for microbiology, and the last for cell counts, which clears any trauma from the tap. Always hand carry these to the lab immediately as stat specimens. For general microbiology, always collect before initiating antimicrobial therapy. Never allow culture specimens to contact antiseptics, and ensure swabs are moistened with sterile saline. Transport these as quickly as possible. If delays are inevitable, follow the specific refrigeration or medium requirements for the sample type. Adverse reactions to phlebotomy must be a standalone component of your training and competence assessment. Whether it is hematoma, syncope, or nerve injury, your staff must be prepared to act instantly. Always release the tourniquet before withdrawing the needle for a hematoma to minimize tissue trauma. The risk profile varies by environment. An inpatient is typically supine, with assistants nearby, but an ambulatory patient is often alone and may be fasting. Therefore, always collect from a chair with arm supports, define an observation period, and ensure emergency protocols are posted in every room. Blood bank and anatomic pathology carry the strictest rules. Blood bank requires positive identification by the collector at the bedside, and if no history exists, 2 separate collections for ABO and RHD. Any mislabeled crossmatch specimen must be rejected without exception. There is no secondary acceptance route. For anatomic pathology, every container and slide must be labeled individually at the moment of collection. You must document the anatomic site and laterality on both the label and the requisition to ensure absolute clarity throughout the diagnostic journey from the surgery to the archive. Chapter 5 focuses on transport and accessioning. This is where you monitor the transit time, temperature, and physical route of the specimen. Without a transit record, any defined stability limits remain merely aspirational. Consider the reality of your samples. Glucose degrades in unseparated tubes, while bilirubin and ferritin are light-sensitive. Your transportation policy must account for these factors by specifying requirements for amber tubes, temperature-controlled transport, or maximum transit times, and then auditing that these protocols are actually followed. Packaging must always include a leak-proof primary container within secondary containment labeled for biohazards. Remember that tracking systems are mandatory. If a specimen is untracked, it is effectively lost to the laboratory process. If you utilize a pneumatic tube system, you must validate it for hemolysis against hand-carried samples. When using third-party couriers, ensure they are trained in your spill response protocols. In an emergency, staff should not improvise on a loading dock. They must follow established, written procedures. Receipt and inspection are defined by 8 fundamental checks: identity, completeness, container, volume, condition, timing, temperature, and the logging process. Any discrepancy found at the bench must be resolved before the sample is accessioned. It should never be corrected by the person performing the test. Avoid vague rejection criteria. Your procedures must explicitly state what constitutes an identification, integrity, or process failure. More importantly, define who has the authority to override a rejection, how the source is notified, and what specific documentation is required to ensure the indicator is updated correctly. Maintaining identity after receipt is crucial. Whether you are aliquoting, staining, or archiving, every transfer point is a potential for error. Every secondary container must be traceable back to the primary specimen, and ultimately, to the specific patient. Chapter 6 covers quality. Retention periods are absolute minimums. Local law may dictate longer storage. Ensure your disposal procedures are consistent from the collection point through to contracted third parties. including the respectful management of human remains or tissue samples. For survey readiness, focus on the basics. Have your manual, your training records, and your indicator dashboard accessible. If you stop a collector and they cannot describe your two-identifier rule, your process is not effectively implemented. Build your baseline, refine your training, and prove it works.